Hello, everyone. Welcome to this webinar with SEDS Connective. SEDS Connective is the foremost and user-led charity dedicated to supporting individuals with hypermobility and neurodivergence. I'm here today with Jane Green, MBE, the chair and founder, and also Kelly Harris, one of our trustees. Thank you so much for coming. We are doing a 45-minute webinar, followed by a 15-minute break, and then after that, we'll come back for a Q&A. So please use the chat box to ask questions. Thank you.
So I am Jane Green, and I just want to do a very quick bio because it is part of the story. I was one of those missing students in education. I was considered dim, and I was also stereotyped as neurotic, stigmatized as hypochondriac. So I left school quite early. I didn't really get many qualifications, and that stayed with me for a very long time. I knew I was different, but there was no word for it. There was no word for being neurodivergent then. Later on, I had children. My eldest was very ill. Uh, Lots and lots of issues. I had lots of injuries and infections, by the way, and but we kept being excluded, and I wanted to help, so I decided I had to help teachers teach and learn, and there wasn't anything back then, so I became, well, literally from ground up, just working as an assistant in Portage, special educational needs, and then I did degrees and worked for the largest national organizations, authorities, and led out new initiatives from the government. But I still didn't have diagnoses, and then I had to clinically, medically retire, and I started SEDS Connective because of this, because I'm very lucky to survive, I think. And I did get diagnoses, but I was discharged straight away. But at least I got them, and I thought there's no support for us, all of us. So that's my story, and I'm now going to pass you over to Kelly.
Hello, so I'm Kelly Harris, and I was a full-time practicing nutritionist. I no longer practice. However, I am now a very involved trustee for SEDS Connective charity. I am neurodivergent and I have hypermobile Ehlers-Danlos syndrome, which is a form of hypermobility myself. I have a child, a primary school age child, um, with the same issues. And I am one of the volunteers who help run support meetings for people with our conditions in the Brighton and Hove area. So, to start with, what is hypermobility? What we know as joint hypermobility is a lot more than just joints. And hypermobility can be found throughout the body. It can result in some really extraordinary physical attributes and abilities in people like us. So we can be very talented at dance, ballet, gymnastics, circus performance, and other types of athletics. But there are really significant health issues that can come with hypermobility. And today we're going to talk about some of these.
We are called SEDS Connective for a reason. We don't have just autism or just ADHD or dyspraxia in the name, or hypermobility. And so we're going to talk about connective tissue, but this is just to show the umbrella of just some of the symptoms and conditions we can have. Some of them probably more prevalent when you're adult than children. And these are growing and evolving as we speak. So bear that in mind. This is like the connective tissue umbrella, but the science is still evolving as we go. We do say symptomatic hypermobility for a reason. It's, as you might have heard already, it's quite rare to get a diagnosis anyway, even for an adult. And I'll explain more about that later. But what I want you to look at is the very common symptoms and conditions we see in children and young people. Don't worry about the actual those letters, nosology, terminology. It's almost like alphabetic soup. So we use the hypermobility just for simplicity, but what it's often seen as is something different, and they're not connected. And that's what we're doing, is connecting the mind and body. So often you find children and young people are tired, maybe extremely tired. They have emotional dysregulation, they're burnt out, they have brain fog, they're confused, they avoid things, they have dizziness. There might be other reasons for that. They might have, it does exist. We do have eating disorders and ARFID and racing heart, but there might be other reasons for that that are physiological. So just bear this in mind as we go along. Often we find, and there is evidence for this, a lot of allergies are there. They're often visuals like eczema. Rhinitis is always a runny nose, like hay fever, that sort of thing. And there are reasons for that as well. So the itching, there are often toileting issues, delayed toileting, and other issues with that go along, like holding their stomach a lot. Clumsiness, poor coordination, floppiness. You see it in the classroom, they're not sitting up straight, and you might find me moving around quite a lot. And I do try, and must be really annoying for people watching me on webinars, but I do tend to move quite a lot. And quite often you can see bruises and scars on children for no apparent reason, which obviously is a safeguarding issue. And as teachers, that's a very serious thing to look at. But there might be other reasons, and that's why it's so important to know about hypermobility. Not everyone has, people think hypermobility means you've got really stretchy skin. That's not always the case. Sometimes it can be really thin, almost translucent skin. But sometimes it can also be really, really thick, and it feels like silk. Some people do bruise really easily. It's just like you can blow a bit of air around and they bruise, and some people don't bruise at all. But it's quite extreme, the two areas. We can also get joint pain and soft tissue injuries, and that's because, well, I'm going to go into it a lot, but sometimes again these occur without previous trauma, which also could be a safeguarding issue, not only for the education staff, but also for parents and so on. So it's what we're seeing through this is knowledge and understanding, and practice is key. The senses. So we know, we'll talk about the senses a bit more, but there are a lot of issues with balance, proprioception and interoception. And we've done quite a lot of work on this as well. So this is just one of there are lots of other symptoms as well and crossovers, but this is just one part. And we're going to go into them a little bit more. The evidence science probably connects these most. At the moment, it's autism, dyspraxia, ADHD, and Tourette's. But we think it's very likely it's dyslexia, dyscalculia, and probably something called dysgraphia, but there's no data on it. And what it is likely is that our connective tissues are different from the general population in some of these neurodivergence there. A neurodivergence is having a brain that behaves and learns and processes differently from the neuromajority. So we are neurodivergent. We are not the neuromajority or neurotypical. And so in neurodivergence, connective tissue is likely to be different. This science is still evolving. I've been doing this since, well, 2015. People have been doing it longer than me. But, when I was training, I always saw the pattern. I saw patterns of symptoms and conditions, but we didn't have the science then. There was no name for it. And this is why it makes so much sense now. So I've talked about connective, and it's in our name. Why do I keep talking about it? Connective tissues found throughout the body, as Kelly said. And one of the proteins in there is something you've called collagen, which you will have heard of. There are some other bits and pieces in there as well. And connective tissue is found throughout the body in specialized areas like cartilage, joints, some muscles and nerves, the nervous system, bones and bloods and vessels, and affects some organs. And it's so basically throughout the body. Now, these genes that are slightly different, like the collagen, the protein is slightly weaker. It's more elastic, it's more bendy or flexible than the neuromajority. And therefore, it means we're more bendy, basically. It is heritable. So it can mean it can pass directly or indirectly. It can jump a generation and so on. It doesn't mean all children will have it or in the same way at all. And it can also affect the autonomic nervous system. And that's really important because you've got the sympathetic and parasympathetic systems. And basically, it's about the systems we don't need to think about in the body. They help with our rest and digest, but also are very, very key if we've got a big, a big spider or a big leopard about to jump on us. We need that response for either fighting or running away. So that's really key, but it does really affect that. So if this is quite an old one, but if you think of a house being built and you've got different builders at different times, and some of them disappear and you get a new one in, and they're all using different types of ingredients or different quantities for building the house. So with the sand and cement and water, some will use more sand, some might use more water, and this will affect the different sides of the house. So you'll get a really, really bendy, wonky house, quite an extreme there. And then you add in the waterworks and the gasworks and the heating and the electrics. And then you add in the temperature differences in the house and climate. You add in the furniture. You add in people. This is all going to add more strain to the house. And what happens is it basically explodes and booms, particularly with us, going back to humans, with hormones in the mix as well, or injuries or infections. These are all in the mix of why we seem to suffer quite a lot with health. So what is the connection between neurodivergence and hypermobility? Why is it important? These are the questions you need to think about. You know, years and years ago, autism was associated with a really, really narrow cohort, autistic people, males with a severe learning disability or savants, and usually always an affinity for trains. Our understanding, so I was not allowed to have any diagnosis. There wasn't, I don't think there was any person like me, and particularly later on as middle-aged with brown hair, although I used to have multicolored hair at one point, there was no name for it. So our understanding has evolved significantly, and we now know that more girls and women are being diagnosed, both with ADHD, different types of ADHD, and being autistic, and more. So that is growing. 30 odd years ago, when my eldest was born, it was very rare. Just literally learning disability boys, I would say, that weren't meeting their milestones at all. So it was quite obvious. Now the prevalence of autism is growing in girls and women as well. What's really interesting is how if you have something called Ehlers-Danlos, which is one of the terminologies of hypermobility, a study in 2016 shows your 7.4 relative risk of autism and 5.6 of ADHD. And then another study later on, which I'll come into, shows that if you're neurodivergent, i.e. ADHD, autistic, dyspraxic, or Tourette's, in this case, that's why we pick on those four, you're more than double likely to have joint hypermobility, so differences in connective tissue, have more pain and more dizziness. And that was a study about 2 years ago. So How does this affect educators, researchers, other allied professionals in school? It's really, really important. And we're going to hopefully indicate where you can go next. The key thing we believe is it's not all about the head, and it's not all about the environment. It's about the body. We are joined up. It's almost disingenuous not to involve the body because we're joined up, the connective tissues all around, and we live in the whole environment. This is neurodiversity affirming. To not include the body, the physiological aspects and symptoms and conditions is not neurodiversity affirming. We need to connect, and that's what SEDS Connective does. So hopefully this will grow, and we were delighted. We are named on for this on versus arthritis, for example. The Royal Society of Medicine recently recognized us. Oh, there we go. Sorry about that. And the Royal College of Psychiatry have mentioned the connections as well. So we're really, really glad our advocacy is helping here. Now, if you remember that umbrella at the beginning, I said it can affect confusion, dizziness, brain fog, executive functioning, and you're going, I think so. So these two studies came out last year. Our patron is the leading researcher in the world, Dr. Eccles, and team, and other teams, by the way. And what this shows basically is, particularly this top one, proprioception is one of our inner senses. We have three. So you probably already know this. And we have interoception, proprioception, and the vestibular sense. And the proprioception one is about knowing where we are in space, where our limbs are. And the reason I believe, always did, the reason we need to move a lot, and basically is to remember where our limbs are related to us and in space, so we don't keep hitting things or bumping into things, because that's quite common. And sometimes we just don't have that connection. I can't always know what my muscles are going to do. So we just find it really hard to understand. And it's a combination of interoception and proprioception. So proprioception is very, very key with dyspraxic people, as you might know, or DCD. And so you could look at it like that. And basically, this is saying those people have proprioception differences, like dyspraxic people, and very key in hypermobility, because that's our key issues, proprioception as well. Is that we have more issues, and it affects our emotional regulation of differences, and it affects our health. And these people are usually hypermobile, but do have a look at that study later on. And the other one is about chronic fatigue, that teenagers are more likely to have chronic fatigue, and inflammation is the underlying mechanism for that. So the other reason we get executive functioning issues is that, and dizziness and fatigue and so on, is something called dysautonomia, quite a long word, but you might have heard of something called POTS, or orthostatic intolerance. And this is very, very key, particularly from the age of about 12 to 50. If you look at secondary age in particular, and particular those born as females. So hormones are key here. And Kelly, did you want to see something on dysautonomia or POTS at all?
So yes, as someone who has POTS in my little list of diagnoses, it's something that can affect our temperature dysregulation. It can, when we stand up too quickly, then we can end up fainting, or something called presyncope, which is where you feel as if you're going to faint and you get a bit fainty, but you don't quite faint. Um, and it's just basically your body's trying to regain homeostasis and normalize itself, but it's a little bit slower and doesn't do it quite as well as it ought to.
Thank you so much. And I don't have POTS. I do have dysautonomia issues, but I always think it's really important that we hear from people who have it. I have this in a way, in a slightly different way, so that we can go into it far deeper than this. But so this is one side of it, but it can also affect your temperature. You can have issues with heat, with cold, with doing activities, standing. I used to do a lot in the airports about, why we have so many health issues in airports. It links to issues with allergies and smells and the environment. So that's where the environment's so key. But actually, it could all be linked to this as well. And what's anxiety is really key here. Absolutely key. It's not all in the head. So what happens is sometimes it can be in the night or early morning or even in the daytime, and your heart starts pounding because gravity, your blood is going down pooling down to your feet. The oxygen's not getting to your head. Now the heart is really clever, and it knows that, so it thinks it has to get that blood back up there. We think it's probably due to the connective tissues and vascular system. So it starts pounding really, really hard. Now that makes you feel quite uncomfortable, actually. It's really unpleasant because you're pounding, pounding, pounding. And then you feel hot and sweaty, and it makes you feel anxious. But in fact, you weren't anxious mentally for any other reason before. It's the whole physiological thing. And without oxygen in the brain can make you feel really dizzy. So that's all part of it. And I know although I don't have POTS, I do get that. And it's quite unpleasant feeling the heart. And you can get very high heart rates. And you also get very low because we're quite extreme, as I said before. So that's what happens basically. And laying down often helps these symptoms, or keeping your feet up. So there's a little tip for you. We do have other tips going forward because this affects a lot of, as I said, particularly at secondary age. There we go. There are lots of issues here. There is a paper on our website. We put papers on there where we can. And this paper came out only last year, gastroenterology. 90% of people with hypermobility EDS and spectrum disorders, so they're diagnosed, but don't worry about those terminologies. Basically, hypermobility commonly have these gastro issues. Kelly, I can't remember if you wanted to come in here on the nutrition or anything.
Yeah, so I was just going to talk very briefly about, I think a lot of educators will be very familiar with the concept of ARFID and sort of the psychological reasons that someone may choose to avoid foods or certain foods. But sometimes the driver for food avoidance and food avoidance of certain types of foods may be due to actual physical pain. And this can be due to a combination of factors. It's the poor interoception that we have, combined with potentially a variety of issues throughout the GI tract. Now, this can coexist with ARFID as well, but so if we start with TMJ issues in the jaw, it can be very painful to chew certain textures of food. And then moving down the tract, we get to things like GERD and gastroparesis and IBS, food intolerances and allergies, and there's a raft of other potential reasons. So we do actually have for people some nutrition resources, some by myself, some by I'm not producing anymore because I am not practicing at the moment, but we do have a SEDS Connective dietitian who has produced some wonderful resources for us, and these are available to anybody on our website.
Thank you, Kelly. Yeah, so these are some of the issues we have, and often with you might have heard of ARFID, which is one of the we can get eating disorders, but sometimes if you have pain and or nausea and or bloating and you can't articulate or express it, particularly when younger or even older, it's very hard. And or you've been disbelieved all your life, it's very hard to get that across. And I know even as an adult, I had these issues and I didn't know how to explain it. And all the tests come back negative or don't meet certain criteria. So you feel like a fraud again because it's sort of built up, and that can lead to anxiety as well. So it's sort of, I'm sorry, some words are cut off there, but basically you can get a food phobia. And that can happen because you know the food is going to cause you pain. Sleeping issues, we think, are very much linked to dysautonomia and the circadian rhythms because of this. Energy levels, absolutely. So when you have floppier, if you like, collagen, connective tissue, sitting up straight or standing straight takes a lot more energy. It takes a lot more muscle. And so strengthening is really key. But to do that takes more energy. And if you've got injuries or infections and so on, it all depletes it and you become more inflamed. And that can become a sort of ongoing circle, if you like. So that's quite important. And it is quite hard to keep free from injuries at times. Our eyes can be different, our teeth and gums can be different. I know I was often accused of not looking after my children's teeth and giving them too much sugar, but in fact we can have differences in the gum because of the connective tissue and also the enamel. So I do understand that. Feet, ligaments, we often need special orthotics, special feet, insoles, and so on. And then we've got the hormones, as I said before, kicking in, particularly at puberty. And they have a significant impact monthly because of the mainly progesterone can make us more clumsy and more susceptible to pain at that time. And there are also lots of maybe crossovers with endocrine issues as well. So this is a slide we have quite well known on interoception. It's our eighth sense, and it's very, very key for us. So we've done quite a lot of work on interoception over the years. In fact, I presented on this back in, I think it was 2018, somewhere down on the South Coast, on the first thing about this and anxiety. We can't always tell if we're hungry. We don't know if we are or we're not. So suddenly you might find some of your children saying, but they haven't eaten all day, or they're suddenly really, really hungry and they need to eat more and more. I know so many times, seeing my own child and other children, they might have the most horrible injury, falling down or something like that, and don't see it, don't feel it at all until they see the blood or something. Or they have just, well, I'm like that. I have a cut on my finger, a paper cut, and I think the world's collapsing, but I can have the most awful injuries and illness and been discharged because I didn't show it enough. There's a pain scale from 1 to 10 called FAS scale, and it never works for me because I don't always smile when I'm happy and I don't always frown when I'm not happy or distressed. So for me, that never worked, and we designed some other things. And also we can't articulate it or express it again. So it's very hard to know. And the same with itching. We don't know if it's an itch or we're hungry or what. We don't know if we're tired until actually yawning. We have to learn that. But it's particularly key for toileting, knowing how your heart is working, am I shallow breathing, and pain. So for me, I believe strongly that we learn to mask pain because we don't know how to express it, and there's no trauma before because it might have been building up for hours before that. So this is just one of the main ones I talked about, neurodivergent people more than double likely to be hypermobile. But what it's saying here is hypermobility is a mechanism between neurodivergence and orthostatic intolerance, and also between neurodivergence and musculoskeletal systems like the whole body framework, joints and muscular pieces. So hopefully, I'm not expecting you to understand the science, but if you'd like to read more, it's there in the QR code. So how do educators and parents concerned about children help? The very key issue here at the moment is, for me, it's been my passion for many, many years when I was still working, is emotional-based school avoidance. I know about social and emotional mental health. I know I've worked in every single phase of education. I am multiply neurodivergent. I've got multiply neurodivergent children. So I think I have a voice here. And I think for our 15,000 members, a lot of them do feel this as well. We need to be heard. Some of the documented symptoms of EBSA are stomachache, headaches, poor digestion, bowel, bladder, and racing heart. So if you look at that, we need to look at it in a different way. If children are not being believed, the trouble is there's no diagnosis for children for hypermobility. There is a pediatric one, but it's very rare to get it. So the children, schools have to ask the health practitioner, and the health practitioner are not trained in it, and particularly for children, and GPs are not. So they might say, well, they're neurodivergent, they're autistic or ADHD, and they diagnostically attribute it to that. It's EBSA, or it might be anxiety because of being autistic and the school environment and social and emotional based school behavior. So, or they might know that they've got a health issue but not be neurodivergent. So this is, I've done lots of professional articles. I've got a publication out, a peer-reviewed paper on this. So do have a look at it. We've got lots on our Linktree and lots on the website, so you can look at all of these as well. But the peer-reviewed paper is the first one, linking up hypermobility, neurodivergence, and education. And there are just some more there as well. But I do believe, we do believe, and I present regularly for all ages in education, until these disorders are widely recognized, children and young people will continue to be misunderstood and not attain or achieve in education. Very often I presented at global learning conferences and other things, and these often came up, which I'm sure you can look at on the video later on. So I won't go into read them all out now, but you are more than welcome to read them. We get a lot of testimonials and quotes from teachers. So today's disbelief, children and young people in pain are the future's chronically ill and traumatized adults. When I did a very large, I'm a fellow at Chartered College, when I did a very large training there about a year ago, I had advisory teachers there, so sort of my peers in a way, and one said she'd worked with hundreds and hundreds of young autistic people and some ADHD, and only a small had been diagnosed with EDS. And I said, yes, well, they won't even be diagnosed with EDS now. I said, yes, that's probably right. She said, only 3. I said, yes, that's probably right. She said, but every single one of them had these issues you were talking about, like pain and anxiety and stomach pain. And she was just gobsmacked, the light bulb went on, and it gives me goosebumps that that's going to change quite a lot. So what can you do? Who are we? This is who we are. We've presented at various conferences all around the world. We've been recognised by the Royal Society of Medicine, as I said, and other areas, and we're all different. There are lots of tips you can do. We think a lot of children need breaks. You need to review the child, both the physiology and what you know about everything else. Don't forget, parents do not often know about it themselves because they haven't been diagnosed. There's something in psychology called you don't know what you don't know. So when people say we've discussed this with autistic groups or ADHD groups or their parents, just remember that they don't know what they don't know. This is new science, relatively. It takes a lot of years to break through, as I'm finding out. But you are more than welcome to use these, which were co-developed. We believe we need support in the classroom. A lot of people say you need special science support chairs. Stools don't always work. You might need the feet up because of the POTS. Pen licenses are an issue because of handwriting and the ligaments. We often say this is hiding in plain sight. And you might need slanted supports to write, not actually be slanted yourself. Access to support. They might need, wheelchairs at some times, but be running at other times. I actually, my passion, as I said, was this. My idea was also to do a school toolkit, which I did with other charities, and I created the content, which you are also welcome to look at, although it is out of date, so we're hoping to do more. And it affects a lot of people taking exams, especially later age, because of there's no evidence from the medical practitioners for this. It's very hard to get extra support in examinations, JCQ. So that's something we're working on at the moment. I would say takeaway tips: neurodivergence, think hypermobility. Hypermobility, think neurodivergence. It's often invisible, but can be visible as well. So just some more slides you can always look at when you want. We just put this in another slide. This is where you can find us. We really thank you. I have gone over. No, I'm exactly on time. Alice is going to be so happy with me. This is where you can find us. Do have a look at our website. We welcome all support. We are a mix of professionals from all areas, parents, carers, people affected by this, friends of people affected by this, and we all have a really, really coherent and close aim to make a difference for the future. That's my paper on the right with our pain advisors. I've forgotten Bethany Donaghy and Dr. David Moore at Liverpool University. So remember, it's a brain, body, mind, body connection, and we are SEDS Connective. Thank you so much.
Hello, everyone. I just want to say that we are all voluntary and user-led, and we welcome any support. So please head to our website, and there is a Get Involved menu button where you can fill out a form and get in touch. We're now going to do a Q&A with Kelly and Jane. We've had a few questions come in, so thank you guys so much for that. What are some typical signs to look out for in a child who may have a hypermobile condition?
So my first thoughts are in the classroom. Wiggliness in the chair is probably a really obvious one. It might go be sort of between being very, very active and wanting to get up and move around the classroom a lot and struggling to keep them in their seats, to then them being a bit fatigued, floppy, just, really struggling to actually even keep their head up. And it can range between those things, even in the course of a day or over the course of a week. Feeling a bit fainty even can happen. Jane, do you have any other thoughts?
Depending on the age of the child, but I would say definitely allergies. are key indicators. Bowel, bladder issues, eating issues, lots of infections, if they get lots of infections. And yes, absolutely, movement, extreme, either not moving and chronically is sort of always tired or always on the run, need to move, because that's key too. I think eyesight and teeth are also quite good indicators. Headaches, but children do not always understand headaches. They don't understand or can express it or articulate it. And often, well, I mean, this is common in adults. We don't eat or drink enough of the right stuff or drink fluids because it's really boring. And I'm talking about water and fluids, but we have to because it's very important. And obviously some children do need medications as well. So what the thing about hypermobility, some will be quite severely ill, extreme, but they will have individual health care plans and so on. And or EHCP, well, it's written down, but a lot will not. So some will be tube fed, for example, and or be in wheelchairs, but some is almost invisible. You can't see it, but it can be really severe and affect people later on. So those are the key areas I would look at first. I don't know if that helps, whoever sent that message in, but yeah.
Can I just
Thank
say,
you.
they can appear very healthy and robust looking. They're not going to appear necessarily as if they're a really sort of poorly sickly child. It can be very tricky to identify.
Yes, exactly. I mean, I don't like to put the doom loading thing on. The whole thing about this is to make sure that they can do what they can do safely. So we get a lot of dancers, gymnasts, the sport people, if you look at that, being artists or musical, really excel because of the hypermobility. And or other passions. I did have to help children who really like kickboxing. We often sort of would say don't do high impact sports, but you know, if you're neurodivergent and that's your passion, then it's very hard to say don't do it, but you have to do it in a very safe way and know what the risks and dangers are, and also know when to stop and what can help support you. So we've got a lot of dancers in our membership because a lot of dancers are hypermobile naturally, and but it's when they stop training or get injured, they get the issues. In fact, one of our musculoskeletal rehab specialists has just done a research science degree in dance, and she was a prima ballerina, so you know that's what happened to her, and that's where she's taken this line in. So that's quite interesting as well. So yeah, but what I want to say is we don't want to promote that you've got this thing and it could lead to this. That's not what it's about. It's about helping and supporting and managing this so these children have equal opportunities in education and employment and quality of life later on.
How best to advocate for your neurodivergent child to get input from healthcare for suspected hypermobility/EDS that looks at this whole picture when the NHS is still working in such silos around support for neurodivergent children?
Okay, I think I've got the hang of it. Just to say, it's very rare now, unless you've got a very rare type, like 1 in 25,000 or 50,000, to get an EDS diagnosis for a child or young person. It won't happen. There are different diagnoses now called pediatric generalized joint hypermobility or pediatric hypermobility spectrum disorder. So you will not get a hypermobility Ehlers-Danlos one for a child unless you've got one of the very rare types, which we haven't gone into here. They do exist. So how to get help? Well, that's why I'm advocating. That's why I'm writing. I recently had a research summary in Chartered Col about this, and I'm doing one for educational psychology who are still learning about this, and clinical psychologists. So it's really hard. It's a really big disconnect. I think they mentioned silos in the question. I think I heard that. It is siloed, and as I said, it's work to be done and advocated on, but this is what we are determined to do, is to connect. So education and health need to join up, but at the moment, we are saying if you're neurodivergent, think hypermobility, and if you think hypermobility, think neurodivergent. Look at our work, share our work. We are on very respected organizations and charities, and we are leading this. So that's what I would say. At the moment, I would like to say a lot more, but GPs, are generalists as well, so they don't know about it. They're not trained in it, and there isn't any support there for children yet. The neurodivergence paper, which I talked about earlier, is probably the newest thing we've got at the moment.
Thank you, Jane. And just to add on to that, there's a couple more questions added on to that question. What language should we use and what referrals should we seek to set them up for success?
Sorry, Jane, what's the diagnostic name now they use for children?
Well, it's literally what I said before, so in a way that's been answered. It's pediatric generalized joint hypermobility or pediatric generalized hypermobility spectrum disorder. What a mouthful. That's why I always say hypermobility. There is a paper on it. You can look at the criteria. The other adult criteria for all 12 or 13 types is on the EDS Society. You can look at the criteria there. It's quite involved. The Baton scale is which we saw earlier, is quite key, but that's for joint hypermobility, and that's just part of the criteria. But for children and young people, it's a very good indicator after the age of 5, because honestly, children are all hypermobile. They can put their legs right above their heads, and they do it quite a lot as young children. But if they're doing it after age of 5 and the Baton scale is really high, you need to consider that, because that's a key indicator. Not so much for adults, because we get more stiff, arthritic, and in pain. So that's why we're not bendy, we're actually stiffer as adults, which people don't realize either, because hypermobility is a strange word, isn't it? For success, that's such a good question. I love that. I think support management knowledge practice and let's pioneer this and make it bigger. That's success.
Thank you so much. And I have one more question here is, would there be issues during premenopause too? Thinking of undiagnosed parents.
Yes, hormones are absolutely key. Absolutely key. As I said, if you're in an accident or you have an infection, infections like we used to have things like glandular fever, Epstein-Barr, other sort of viral infections, including long COVID, interestingly. A lot of the symptoms and conditions there are very, very familiar to us, very familiar. So hormones, yes. So puberty, pregnancy, contraception, perimenopause, post-menopause itself can be that house exploding. That's what we often see, and post-menopause. So you don't often get people past 55 with POTS so severely, but they will have dysautonomia, but not so much POTS. And we think that's probably hormone related. So yes, we are quite extreme as usual. So some people might have very early perimenopause. Some will be not have any symptoms, but be extremely late. But there are lots of issues with the urinary I can't pronounce this tract, prolapses. We didn't put everything on there because it could go on, but we do have quite a large proportion of people with those issues. Yeah, so anything you want to say, Kelly, as well? Have I missed anything out on the I'm thinking prolapses, gynecology and stuff like that. I think there's so much.
Yeah, I mean, most of us will have, especially if we've had a pregnancy, will have some degree of prolapse in the uterus. in terms of the toilet issues. And this is for children as well as adults. IBS, almost universal. Interstitial cystitis can be fairly common. And again, that's one that's really difficult to pick up because, you know, the child may not, it is quite a painful condition, but the child may not be able to necessarily recognize that pain. And what you may see as a teacher is a child going to the toilet a lot. And sometimes this can be interpreted as a behavioral issue and not wanting to be in class, or it may be interpreted as them just wanting to get up and move around. So it can be a really tricky one to get to the bottom of, the toilet issues.
Yeah, thank you. And also, I have noticed also secondary age, we get quite a big inbox. We've got a huge inbox if anyone wants to help. Secondary age girls actually being ridiculed almost by their peers because they are still wetting their, you know, they have troubles with their bladder. So and you know, it's just really hard for them. So they're trying to avoid school now. So attendance is key there too. But yeah, hormones are absolutely key and definitely can be part of the whole mast cell activation, which we haven't gone into too far because it was such, you know, that we could talk for days on each subject, to be honest.
Would you be able to explain MCAS a little more and its relationship
Oh,
to hypermobility, please? There we go. Also
that was
for
really good timing.
also for the associated autoimmune conditions, do they follow a pattern of peaks and troughs?
I've just heard the first one, so I'll go on that first. MCAS, I mentioned dysautonomia a bit. So we think that there are cells in the body called mast cells which overreact. So you know that fight flight thing I was talking about with a big leopard about to attack us or a big spider. We have that fight flight response to quite a lot. It can be triggered quite a lot in certain areas, and sometimes it sticks there a little bit. But our mast cells can get like that too. They get overreact to things that really aren't harmful to us. But it could be perfume, it could be cat dander, it could be dogs, or it could be even the environment they're in. It could be food. And we don't always know what it is causing it, but it could be the link between mind and body. So it could be anxiety led, as in mental stress, anxiety, or it could be dysautonomia, anxiety and stress, or it could be a whole combination. We're often lactose intolerant. That can cause a lot of issues. We think probably eczema is a key indicator here of mast cell. If you ever go to a hot country and get mosquito bites and they really get much bigger than everybody else's for no good reason, it's just not fair. Those are probably your mast cells overreacting. I've forgotten the question, by the way, but yes, MCAS is very hard to diagnose. We put it down to be, you know, it comes under hypermobility really. It's a combination of chemicals, and I won't go into it too far. I've written about it a little bit. Hay fever season is particularly key, and I know Kelly has a lot of information about this herself if we've got time. Otherwise, do look at our website. Kelly, did you want to say anything extra that I've forgotten?
I mean, not to get too sciencey about it either, but there's a lot of new stuff happening with MCAS in connection to small nerve fibers. And it's very difficult to get the testing done on the NHS, but there is a test that can be done to check for abnormalities with small nerve fibers.
Also, for associated autoimmune conditions, do they follow a pattern of peaks and troughs?
I don't know about the peaks and troughs, but there's definitely a crossover with autoimmune and endocrine issues. We have an awful lot of members with crossovers: thyroid, Graves, lupus, Sjogren's, endometriosis, adenomyosis, rheumatoid arthritis. I've probably forgotten some Crohn's. Have I mentioned that? There's a lot, but the evidence really isn't there or data there. But there must be adhesions and things going on somewhere. And hormones. But all I can say is anecdotally, yes. Peaks and troughs, probably. Kelly, anything else?
No, I think it's just one of those things at the moment that we have noticed correlations, but there's nothing really specific yet to connect those autoimmune conditions to the
It's
hypermobility.
very, very exciting and interesting development. So you know that umbrella, it could just get much bigger.
But we have to remember it wasn't too long ago that we didn't actually know the connection specifically between the hypermobility and the neurodivergence, but we strongly suspected it was there. And it's only in the last few years that we've had the evidence base to connect the two. So it's just kind of a watch space.
Yeah, thank you.
Thank you guys so much, and thank you so much to everyone for joining. And yeah, please head to SEDS Connective website for more information and resources. And yeah, on our link tree, you'll find our Instagram, Twitter, well, X now, LinkedIn, and yeah, Blue Sky and all of that. So yeah, thank you so much.
Thank you. Thank you. Bye-bye.
Bye.